committee on.
Right. I'd like to call the Committee on Health and Human Service Policy back to order. And so, members, we have a motion before this body, and we're going to take a vote on that. But before we do that, I would like to make a statement, and then we would take the vote. Representative Robin.
Thank you, Madam Chair. I just wondered after your statement if I could speak to the motion.
I think we had, I hear we have plenty of discussion earlier. There's a motion before the body, and we're going to take a vote.
Madam Chair, we had no discussion on the motion.
Well, I think Representative Albright spoke to the motion, and spoke to the motion.
Madam Chair, is it a debatable motion?
It is a debatable motion.
We literally there was no opportunity for members to discuss the motion.
Okay. So I just want to say, on the last day of the first deadline, with 19 bills before this committee, it is my wish that we get through the bills of this body. There is a motion on the table, and one of the things that, I don't want to get into really too much of the motion. What I'm going to do is do this, because I believe it's a debatable, so we're going to give you time to speak to the motion before we take the vote. I'm going to let you guys go first. I'm going to put a time span on this conversation, on this motion. I'm going to end it with a statement, and then we're going to go to the vote. Representative Robbins.
5 minutes.
Thank you, Madam Chair. I'll keep my remarks brief. I just wanted to support the motion. I attended the press conference the other day about the OLA report, and I think it would be very helpful for the committee to hear from Ms. Ham so we can ask her our questions about the transparency and the investigation. So I support the motion, and I'll defer to my colleagues.
Okay, Representative Noor.
Thank you, Madam Chair. I also would support the motion. The biggest problem that we saw in that OLA report is a lack of accountability by Ms. Ham. And I think that there's a reason that we have subpoena power in this body. And I think, this is something that we very rarely exercise. And I think this is an instance, and is very specifically in the purview of this committee. I think that this is an instance where we've got a pretty extreme circumstance here, and I think it would be wise of us as a body to exercise that authority to get to the bottom of this. There are clearly a lot of unanswered questions, particularly on accountability, and I think it would be very appropriate for us to do that. Thank you, Madam Chair.
Thank you, Madam Chair. And first of all, you mentioned you're going to set a time limit. I just wonder if the chair could first tell us how long each side will have to. I would suggest 5 minutes and 5 minutes, no more.
Representative Chair, it was going to be my statement to make a total of 10 minutes.
Okay. Thank you,
but it may
Madam
not even
Chair.
need all that time,
All right.
because I'm hearing from different folks.
All right. Thank you, Madam Chair. And I would just like to say that, first of all, this is an issue that does not belong today. And, very serious allegations were made against the Somali community. People threw around words like terrorism and made really very inflammatory allegations, which the OLA found there is no evidence to support. Now, yesterday, as you may know, in Christchurch, New Zealand, 49 Muslims were gunned down in 2 mosques, I believe it was. So when you make allegations like that, it is very, very serious. This goes far beyond politics. because people listen to what we say. And sometimes they take it beyond where they should. So I just wanted to get that out there if we're talking about this OLA report and the allegations that were made. Now, there is a time for us to examine how funds are used. There certainly is. There is a time for oversight. There are parts of the governor's budget that address the CCAP program, that attempt to get better control over that program. Let me just say there are many areas of our budget that we need to do better on. For example, the nursing home industry that got a lot of money from us a few years ago, there are pieces there we need to relook at. There are pieces in the DWRS system we need to look at. There are pieces in the eligibility for our public programs we need to look at. There are a lot of things we need to look at and do oversight on. But this is the day when we have the deadline for policy bills to get through this committee. And bringing this up today and trying to use a lot of time on it, I believe is a stunt and trying to pull the committee off its business of today. So, Madam Chair, I believe we should vote down this motion and get on with the business of this committee. And these issues will be there for another day. And I also want to say that Ms. Ham, I'm perfectly fine with questioning her, and there is no need for a subpoena. I've been told that she'll come before the committee anytime the committee wants to hear from her, but that is not the business for today.
Okay, we have about 4 more minutes left if the Republican side would like to speak
Madam Chair.
to the,
Madam Chair,
yes, Representative Albright.
I would speak in favor of my motion and to some of the comments that I've already heard. The OLA report, as well as the report that PFM prepared, as I would read it, makes no reference to ethnicity. What it does do is refer to fraud. It is blind to ethnicity. The circumstances surrounding the investigations and the prosecutions that took place, some might infer, but there is no reference in the body of the OLA report that would impugn any cultural sensitivity. The purpose of this subpoena, purely and simply, is to draw the weight of the importance of the investigation that was conducted by the OLA, as well as the independent audit that was requested by DHS and the OIG. To the extent that it delays what we are in this committee about, I think serves up the importance of taking up this conversation, and to the point that we want to make sure that it is in a timely fashion. There is another report that is upcoming in April that the OLA has already announced, and in light of that, and in light of the severity of and the significance of the findings by both reports, I think it is imperative that we bring this forward, and I'm happy to take a vote as soon as my 4 minutes are up. I think it's important that we put it on the record in terms of the importance that each one of us weigh on the importance of this. And so I'm without a doubt assured that by that we will all agree that we want to see Ms. Ham in front of this committee for the purpose of hearing her side of the investigation and how she intends to move forward, along with the commissioner of DHS, who I think also should be invited as well. They both have a party to the justice that should be served on behalf of the taxpaying members of this state who use that program, as well as the people that are being harmed by the fraud that is being perpetrated upon CCAP. Thank you.
Thank you. I think we have maybe 2 minutes on our side. Representative, let's finish. We have 2 minutes. Representative Pearson on the Republican side.
Oh, thank you, Madam Chair. And I guess I appreciate you allowing this to come to a vote. It's my understanding that in another committee this motion had been made and that the motion had actually been ruled out of order. So I want to thank you for allowing us to vote on this. I think it is important. I think it is timely. Here we are, and I realize we're on first deadline, but again, if we push this off, all of a sudden this committee doesn't meet quite as frequently, and if we don't get this subpoena request in now, we may not hear from Ms. Ham until long beyond that. So I do think this is a great motion. I think the testimony belongs in this committee more than virtually any other, and I really respect and appreciate the fact that you're allowing us to vote on this motion.
I'm going to close with Representative Pinto.
Thank you, Madam Chair. I hope that we all understand the importance of the program, of the Child Care Assistance Program for families and for kids and for all of us. And for that reason, I think for so many of us, it is critical that funds dedicated to that program go to the people actually eligible to receive those funds. And as a prosecutor outside my work at the Capitol, I'm appalled by wrongdoing and certainly by the thought that funds are not being used in the appropriate way, and especially when those funds are to be aimed at families and kids who actually need them. And let's remember, members, that there is, as has been referenced, there is in fact a second report that is being prepared right now by our legislative auditor that is looking into the controls, et cetera, within the Department of Human Services. We had, we were awaiting this report, as was pointed out by Chair Liebling. The allegations that prompted that report have been found to be unsubstantiated and not to be supported at all by the evidence. However, there's additional information that's found, and now the OLA is looking at that information. As Representative Noor said, this step is a very rare one, so much so that I think for a number of us, we didn't even realize that this was even something that could even happen. And so, members, I would urge opposing taking this extremely rare and I think pretty close to unprecedented step. When we have our own legislative auditor that's looking into the very same information, let's get that report, let's get that information in the right way. And in the meantime, let's keep on moving through our process. Thank you, Madam Chair.
Thank you. Okay, so, and I'm going to maybe just shortly repeat some of the things that I heard that it's really, really important that the oversight of this program that is essential to many families, low-income families, that we are working to ensure that the limited resources that we have are going to where they need to have. So fraud and oversight is important to us, and I think it's important to this committee. We do know that there will be another OLA report that's coming out shortly. And what I know from the department, all we have to do is request that they come before this body and they will be here. I personally don't see, and I think many of our members do not see, a reason to have to subpoena the department to come before this committee. We can request it. But before us, we have a motion, and we're going to take a vote on that motion. So, clerk, please take the roll.
Oh, there's no roll call.
Just for clarity, can Ms. Pinelli just give us what the vote would mean?
Oh, because this is,
Can you just walk us through the state statute related to the vote of this nature so that we're all clear on the rules?
Madam Chair and members, Minnesota statute section 3.153 governs legislative subpoenas, and the requirement in the statute is that in order for a subpoena to be issued, the committee has to affirmatively vote by a 2/3 vote of its members.
Thank you. So, clerk will take the roll.
Chair Moran.
No.
Vice Chair Morrison.
No.
Minority Lead Keel.
yes.
Representative Albright.
Yes.
Representative Backer. Representative Bonner.
No.
Representative Edelson. Representative Fisher.
No.
Representative Freiberg.
No.
Representative Liebling.
No.
Representative Loeffler.
No.
Representative Mann. Representative New.
Yes.
Representative Pearson.
Yes.
Representative Pinto.
No.
Representative Robbins.
Yes.
Representative Schumacher.
Yes.
Representative Schultz.
No.
There have been 6 yes and 9 no's. The motion does not prevail. We would take up House File 486 next. Representative Schultz, please come to the testify table.
Madam Chair. Madam Chair.
Representative Newt.
Thank you, Madam Chair. Perhaps while Representative Schultz is preparing, can I just ask? There were lots of good comments about Ms. Ham and making a request for her to come before the committee. Can I ask, Madam Chair, if you can commit to holding a hearing at a later date on this OLA report and requesting Ms. Ham to come and speak before the committee so that we really can do a thorough, have a thorough discussion of this and move bills that actually will help to fix this problem.
Representative Newt, I can't commit to taking that under consideration, but I would like to point out that we do have a subcommittee on early childhood education. And I really believe that if we had to have a hearing, it should be within that committee.
Tossed over to me. Oh.
Representative Cantrell?
Fall into that.
I was waving at Representative New, thinking that she may be tossing the question over to me. But I guess I'll let her. But why I shouldn't jump in the line of fire without allowing her to first aim it at me. So I'll let her do that. Okay. All right. Thanks.
All right. Representative Schultz, would you like to move your bill?
Thank you, Madam Chair. I move that House File 486 be recommended for re-referral to the Committee on Ways and Means.
Okay, we have the bill before the committee. Representative Schultz, please present your bill.
Thank you, Madam Chair and members. House File 486 requires health plans to cover hearing aids of persons of all ages. I have a constituent in my district that have children that need hearing aids, and currently under their coverage, they cannot get them as frequently as they need them. So this would also ensure that children are getting them more frequently as they grow out of old hearing aids and as their needs change based on new prescriptions for hearing aids. And I also have testifiers here, Madam Chair.
Thank you. Okay. To your testifiers, please introduce yourself for the record and tell us a little bit about who you are and proceed with your testimony.
Madam Chair, members of the committee, thank you for having me here today. My name is Patty Morelli-Teachout, and I'm the mother of 2 adult children. My youngest son has bilateral hearing loss. 16 years ago, when my son was 4 years old, I opened my door to an incumbent candidate who was door knocking. He asked for my vote and asked if I had any concerns. I invited him in. We talked for 2 hours and in tears explained to him how my husband and I were struggling financially to pay the $4,000 for hearing aids that our son needed. We were told that his hearing loss would fluctuate and that we would have to purchase new hearing aids every 2 to 3 years. We had 2 young children. We had to borrow money to cover the costs. We didn't know how we would juggle the cost of hearing aids and our household expenses. Our health insurance told us that hearing aids were cosmetic and they would not provide coverage. There was no insurance mandate in the state at that time. Soon after that, Senator Uyghur introduced a bill that would become MS 62Q.675. I had no experience advocating at the Capitol. I found another mom who had twin boys who needed hearing aids. She and I stopped working from January through May of 2003 and became citizen advocates to get that bill passed. We worked closely with the Commission of Deaf, Deafblind, and Hard of Hearing. We worked with other moms whose children had hearing loss, and we got that bill passed. We were able to successfully argue that hearing aids are not cosmetic, that they are essential to they are an essential medical device needed to prevent the serious permanent consequences of untreated hearing loss. The cost to cover hearing aids is less than the cost to society for social, emotional, and educational delays that are caused by the lack of coverage resulting in children going unaided. Here I am 15 years later. That bill was a success. Representative Schultz was approached by her constituent, and she responded to them with this bill. My son has been able to benefit from the coverage in his elementary and secondary education. He has a full social life and is doing very well in school. He is now an adult and he's at the University of Minnesota and does not have insurance coverage for hearing aids. He needs hearing aids just as much now as he did when he was a child. I am here to argue that for the majority of people with permanent hearing loss, the only appropriate treatment is hearing aids. However, health insurance won't pay for hearing aids unless you are lucky enough to be a state employee, you qualify for medical assistance, or you're in the small minority who has hearing aid coverage in a commercial health plan. This is not a responsible or fair policy. Please support House File 486. Thank you.
Thank you so much for your testimony. To the testifier, please introduce yourself. Who you are.
Madam
and
Chair-
proceed.
Madam Chair, members of the committee, thank you. My name is Emery David Dively, and I'm the Deputy Director at the Commission of the Deaf, Deafblind, and Hard of Hearing. The Minnesota Commission of the Deaf, Deafblind, and Hard of Hearing hosts a cross-agency, cross-sector task force that focuses on age-related hearing loss. Our commission is on its second task force, and it works on proposals that will guide us in our work for the next several years. This issue, the cost of hearing aids, has been a primary issue that our task force and our commission hears about every time we collect stakeholder community feedback. The commission is committed to improving people of Minnesota's access to affordable hearing health care. Nearly 20% of all Minnesotans have a clinically significant level of hearing loss. Hearing aids are needed for deaf, deafblind, hard of hearing people, but also people who are hearing and then begin to lose their hearing as they age, whether that's from noise pollution, age, or medical conditions. Despite costing $2,000 to $4,000 on average, and oftentimes much more, and they need to be replaced at least every 3 to 5 years, if not sooner, particularly as they grow up. The vast majority of Minnesotans have no health insurance coverage to help with these significant out-of-pocket costs. This means that many people who need hearing aids are not getting the help they need when they're in college, to be productive or successful in their workplace, to connect with families and build relationships, and to age in a healthy way. People desperately look to grants, charities, community organizations, or family members to help them pay for these expensive costs out of pocket. Some, like my mother, who is also deaf and I'm hard of hearing, use old recycled hearing aids because she can't afford to buy her own. We know that people who lose their hearing as they age are 2 to 5 times more likely to develop cognitive decline or dementia. They're also at significant risk for increased rates of falling, depression, and other serious co-occurring issues if they're not able to get hearing aid. Cochlear implant surgery, which is invasive and complicated, typically is covered by health insurance plans at the cost of between $40,000 to $80,000. Our insurance system pushes Minnesotans towards this expensive option. Access to family, relationships, news, work, education, and employment all begin with people's ability and access to communication. Thank you.
Thank you so much. Is there anyone else who would like to testify on House File 486? Members, any questions? There being no further discussion, Representative Schultz renews her motion that House File 486 be recommended for re-referral to the Committee on Ways and Means. All in favor say aye. Aye. Opposed? The motion prevails and House File 486 is recommended for re-referral to the Committee on Ways and Means. Thank you so much. The next bill up is House File 2009, Representative Cantrell. So the chair moves House File 2009 to be recommended for re-referral, or 2009, to the Committee on Ways and Means. We have the bill before the committee. Representative Cantrell, I understand you have an author's amendment, and the chair would like to entertain a motion for the A1 author's amendment. So moved. Is that Representative Albright? So Representative Albright moves the A1 author's amendment. All in favor say aye. Aye. All opposed? The motion prevails and the amendment is adopted. Representative Cantrell, please.
Thank you, Madam Chair. Thank you, members of the committee. It's a pleasure to join you today and to present House File 2009. What House File 2009 does is it prohibits health plan companies from acquiring health plan enrollees who are battling stage 4 metastatic cancer from progressing or from having to progress through a standard step therapy protocol in order to access or have the medications covered that their physician believes that they need to be on. This is a pretty, I would say, good step in the right direction. It has bipartisan support in both the House and the Senate. This bill also has support from the Susan G. Komen Foundation. As far as making sure that cancer patients, especially cancer patients who are in a very late stage of cancer, are able to get the medications they need in a manner that's affordable, I think this bill is a small step to where we need to be. With that, members, I'll yield for questions, and I ask please for your support.
All right, thank you. Is there anyone else who would like to testify on House File 2009? Any discussion, members? There being no further, Representative Albright.
Thank you, Madam Chair. Representative Cantrell, thank you for bringing this bill forward. I'm a co-author on the bill. I just have one question for you, sir, and it has to do with the effective date of the bill. I'm wondering why we would want to delay people having an opportunity to be provided with these type of therapies any longer than they need to. So if before it passes into law, hopefully you would consider a friendly amendment to date it for the day after enactment.
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Albright. I am absolutely amenable to that, and I'm definitely happy before this bill is enacted in its final version to work with you on the enacted date or effective date. Excuse me.
So here, sounds like we're going to offer friendly amendment to it. You're going to accept it?
Madam Chair, if you're willing to suspend the rules, I would offer that amendment.
For this purpose, yes.
Madam Chair,
Representative Albright.
sometimes intentions, even while good, certainly, you can get out in front of your ski tips on things. So our intentions are pure, but I am advised by Mr. Chun that there is some time necessary for the health plans to get up to speed with this provision. So it can't happen soon enough, but soon enough will probably have to be January 1st.
All right, good. So there been no further discussion. The chair renews a motion that House File 2009 as amended be recommended for re-referral to the Committee on Ways and Means. All in favor say aye.
Aye.
All opposed? The motion prevails and House File 2009 as amended is recommended for re-referral to the Committee on Ways and Means. Thank you so much, Representative.
Thank you, Madam Chair and members.
Okay, we have
Appreciate your support.
Just stay put.
Oh, I know.
House File 1257. So the chair moves House File 1257 to be recommended for re-referral to the Committee on Ways and Means. We have the bill before us, members. Representative Cantrell, please present your bill.
Thank you, Madam Chair and members. It's a pleasure to join you again. House File 1257 is a bill that I believe will help to alleviate the uncertainty and the fear of inconsistency in prescription drug coverage that many Minnesotans living with serious and chronic health conditions have to live with. This bill prohibits a health plan from abruptly changing its formula during the contract year for patients already enrolled in drug therapies. The reason for this bill is that this practice often leaves patients, many of whom enrolled in a specific health plan because that health plan will cover the specific medications necessary to treat chronic and often complex health conditions. And it oftentimes leaves people in a situation where they contractually engage in a service because they understood at the outset of the contract that the service met their needs, only to find that, nope, we're going to take away the drug, potentially the epilepsy, the MS drug, the depression drug that you needed, and we'll switch out with something else. The issue with that is the patient is still locked into the contract for the duration of the contract year. So in addition to having to pay already costly out-of-pocket health care costs and already costly premiums, patients are left now having to subsidize out-of-pocket the costs of their prescription drugs, which for these conditions are often not only a very complex regimen, but usually take quite a bit of trial and error to arrive to. And let's see. So under this bill, a health plan can still change its formulary during the contract year. It can expand it to include more prescription drugs, to reduce co-payments, or to move prescription drugs to a different benefit category that reduces a patient's costs. And that's not a problem. However, if a health plan wishes to remove or increase the price of a name brand drug, it must include a generic or brand name drug identified as being therapeutically equivalent in the U.S. pharmacopoeia. Additionally, a health plan is still able to change its utilization review requirements and move a drug to a more expensive benefit category within with the requirement of the issuance of a 60-day notice to prescribers, pharmacists, and affected enrollees, but only if these changes do not affect enrollees currently taking the medication or medications affected by the changes. This really is a bill meant to prevent folks from getting the rug pulled out from under them after they signed up for a service that they initially thought would cover their needs, only to have that security taken away. So with that, members, I'll yield for questions, and I would greatly appreciate your support on this bill.
I believe you have one testifier, Ms. Catherine Schmitz. Please introduce yourself for the record and who you're with and proceed.
Thank you, Madam Chair and excuse me, members of the committee. My name is Catherine Schmitz. I'm here from the Minnesota Council of Health Plans. Just want to make a few quick comments about House File 1257. This bill will increase the cost of health insurance for people who pay health insurance premiums, which includes employers, employees with people who buy coverage on their own, and potentially senior citizens. This bill prohibits health plans from being able to make changes in the drug formulary so that health plans can ensure the most cost-effective use, so that health plans can ensure that they are providing the most cost-effective use of prescription drugs. This bill removes one of the remaining tools we have in our toolbox to manage the cost of drugs. Drug prices can increase at any time of the year, and we all know drug prices for brand and generic drugs are rapidly increasing. If the health plan is prohibited from making formulary adjustments during the year, then it will provide a big opportunity for drug companies to increase drug prices on January 2nd. And this is not hyperbole. This actually happens this past January. A number of drug companies raised their prices considerably on all their drugs. This bill also applies to people covered through state public programs, and during the 2015-2016 biennium, a similar bill was proposed, and the resulting fiscal note was about over $9 million, and that reflects just the cost for people covered through state public programs. We don't know how much the additional cost would have been for the rest of the commercial market or for seniors covered through a Medicare supplemental product. Drug prices are increasing at a rapid rate. In fact, the cost of prescription drugs now exceeds the cost of inpatient hospitalizations. Health insurance premiums are so expensive because the cost of care is so expensive. We urge the committee to carefully consider the trade-offs associated with this proposal. Removing this tool means health plans will be limited in how they ensure the most cost-effective use of drugs, and higher costs will be passed along to people through higher premiums. Thank you, Madam Chair.
Thank you. Is there anyone else who would like to testify on House File 1257? Members, any questions? Chair Liebling.
Thank you, Madam Chair. I'd like Ms. Commit to come back to the table if she would. So, Ms. Commit, you were talking about, you were claiming that this bill would make health care more expensive. I'm wondering, we've heard a lot this session about the pharmacy benefit managers, and we understand that all of the health plans use pharmacy benefit managers. When we talk to the pharmacy benefit managers, they say that they're great because they get discounts from the manufacturers. The manufacturers say that they give discounts, and what I'd like to know is, do the health plans get discounts, and do they pass them along to the enrollees when they get those discounts?
Ms. Commit.
Madam Chair and Representative Liebling, the answer is yes. Those rebates and the value of those rebates do get passed along in the form of lower premiums to all of the people who are buying products from a particular health plan.
And Madam Chair, Ms. Commit, other than you telling us that, is there any way for the public to actually confirm that that's the case? I mean, is there any public reporting that you're aware of that would be able to tell us, even within our public programs, or for people who are buying a private health insurance product? Is there any way for members to know that those rebates are being passed along? Ms. Commit.
Madam Chair and Representative Liebling, I'm sure I can get some information for you and for members of the committee, because the health plans do have to keep track of exactly how much spend is attributable to the prescription drugs, prescription drug costs. And so I think with, if this bill were to be enacted, the spend would be higher, and then the premiums would be higher commensurately. I can also, we'll check on specifically your question about how the rebates and any other discounts are reflected in the premiums.
And thank you, Madam Chair. And, you know, the other piece of this, Ms. Commit, even if we just accept what you just said at face value, you know, part of the problem with this is that we've heard a lot of testimony this session, and I think in previous sessions, about what happens to people when they're forced off a drug that works for them arbitrarily from their point of view, or because it's, you know, the price went up, you know, wherever the fault lies. And I have to say, the more I learn about this, the more confusing it gets, because everybody points fingers at everybody else in this system. But we know that this has impacts on people's health. And if somebody is on a drug and they get arbitrarily switched to another drug, it can hurt their health. And so I wonder, when you're saying how this is going to raise the cost of health care, well, maybe just let me just make it as a statement. You know, I don't know how the plans account for the fact that that somebody's health may suffer. And we know that the downstream costs, when part of the reason that so much has shifted to pharmaceuticals is that pharmaceuticals often are very effective at keeping people healthy, controlling chronic diseases and so on. And, you know, for example, if a person is on insulin of one type and that insulin is then taken off the formulary, they have to switch, it may not be as effective for them, and they may end up in the hospital, they may end up in the emergency room. So I don't know how we account for all of these costs, but I think that when somebody buys a health insurance product, that they ought to be able to know that the drug that they are looking for, that they're on, that they often go and pick that insurance product because of that drug, they should be able to know that they're going to be able to stay on that drug during the course of their treatment. And I think that's what Representative Cantrell's bill is trying to get at. So I do support the bill. Thank you, Madam Chair.
Thank you. Representative Schultz.
Well, thank you, Madam Chair. And Ms. Commit, my question was somewhat related to what Representative Liebling brought up, in that we as a state and employers hire health plans to integrate and manage care and coordinate across aspects of that patient's life. And by delegating the decisions on a formulary to a PBM, you're separating that from all your other knowledge about that patient experience, and whether or not that leads to post-hospitalization, additional lab tests, you know, try it, see if you like it. I mean, it's always kind of weird when it's like, just try it, see how it works, and come back if it doesn't. That, during the period until you come back, can be pretty disabling for some people. And to what degree are you aware of that the health plans oversee that in their analysis of recommendations from the PBMs?
Mrs. Commit.
Madam Chair and Representative Loeffler, I'm not familiar. I don't work for a health plan per se, so I would have to get that information for you, and I will get that information for you. But I just want to say that, you know, it's not that this is, first of all, the health plans do not intend to harm any patients, but we're simply trying to strike a balance between providing coverage, comprehensive coverage, while at the same time doing it at an affordable and accessible premium. If it's the will of the legislature to pass these bills and to remove some of the tools that allow us to be able to manage the care, to switch to other drugs that are lower cost, that's okay. If you want to pass it, we can price it. But I would also say that there are opportunities for patients to appeal these decisions if they don't like that and that sort of thing. I recognize that not everybody engages in that process, but again, this is, it's very challenging to be able to try to provide a premium for a product while at the same time there's no restriction on the drug company, and the drug company can simply increase the price of the product mid-year or several times of the year, and there's no way to adjust for that accordingly.
Madam Chair, I would just say there is no business that isn't at risk of market changes in the prices of the goods and services they need to deliver. And I see this as a basic contracting obligation. Someone selects a health plan because it has the doctors, the hospital, and for some people, most importantly, the drugs that they prefer and are dependent upon and can trust. And so to me, when you enter into a contract, that premium, when you offer a premium for a year's coverage, that premium says, these are all the things we're going to cover for you, including these specific drugs for the next year. And the next year comes along, you can adjust it, and you might lose that patient who'll go to someone else. But at least it's a patient choice about who they're purchasing the services from and where. And I think it's every business is subject to market change, and you have to anticipate that in your pricing, but you can't, this business is not different than any other in terms of saying the purchaser shall have no say, and the terms of the contract and the deliverables will change throughout the year. They are bound by a premium, and I've never heard of anyone who got that happy letter that says, your premium's going down $50 this month because we found a better, cheaper drug for many of our patients. That's never done. You hang on to it even when you have savings. That's you know, it's an up and down sort of game in setting a price, no matter what your product is. And I think for people who actually actively search for a particular drug and select a health plan based on that, I think that the deliverable of a year is reasonable.
Representative Bonner.
Thank you, Madam Chair. Thank you, Representative Cantrell, for bringing this forward. And I'll try to keep it somewhat brief here. But as you know, I alluded to the other day that my sister has type 1 diabetes. And actually, if you could stay. So just as a course of that, I can tell you that we've actually lived through this in my family, where my sister was forced to change insulins midstream from something that was working for her, which did, in fact, lead to fluctuations in blood sugars. And for those of you who don't know, there are quite severe consequences to that, including insulin reactions in which people could slip into a coma. There are other health ancillary benefits around that, and in some cases can lead to them having a hospital stay. And I'm just curious if you could tell us the average hospital stay, the cost for that. Do you know what the average cost is for a hospital stay?
Mrs. Commit.
Madam Chair and Representative Bonner, I do not.
Well, I will tell the committee, I just looked that up. It's around $10,000, depending on the condition. Now, if we're talking about this policy and trying to save money, I have to be honest with you, this is a bit penny wise, pound foolish. Because let's say we save $1,000 by switching someone to a different insulin, but we spend $10,000 on a hospital stay. That's a problem. And I can tell you, as someone who did formerly work for a healthcare company, who actually had an entire program designed around preventing hospital readmissions, because they're extremely costly and they drive up the cost of healthcare. That is what is driving up the cost of healthcare. So to be really blunt, I have to be honest with you, I'm not buying your argument because it makes no sense. It's penny wise and pound foolish. If we really want to ensure that we're keeping costs down, we need to make sure that we are ensuring good patient care, that we are keeping chronic conditions stable so that we keep those costs down and we keep our patients healthier. And I think that is the takeaway here today. So I want to thank you, Representative Cantrell, for bringing this forward. And I think we need to do something to, in fact, get healthcare costs down, but we need to do it in a smart way. Thank you.
All right, do you have a question for the
No, I think it's to the author.
Okay, Ms. Representative Albright.
Thank you, Madam Chair. Representative Cantrell, on page 2, line 7, or just in subdivision 2, there's a declaration that specifies that the formulary can be requested either by electronic means or upon request at least 30 days prior to the annual review dates. Is that available to anyone, and what type of mechanism do they use in order to make that request?
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Albright. I think it should be available to anyone. And let's see here, just looking at the language, by electronic means, upon request, in writing. So I think individuals can pursue and work with whatever their health plan has available in terms of communication and contact in electronic means to request that information.
Representative Albright.
Thank you, Madam Chair. And Representative Cantrell, I understand what it says here, but in terms of the, I guess I was getting more at in terms of how do they request it. It's coming back to them either in an electronic form or by writing, or maybe let's just leave it at that. Down further on that same page, lines 28 through 32. They may change or remove drugs from its formulary deemed unsafe either from the FDA, but then further down it goes through. So the FDA typically is the person who would deem a formulary unsafe. But you also in here identify an independent source of research, clinical guidelines, or whatnot. So are there specific sources that are deemed credible that you would want to cite here, or is it just anybody that would deem a drug unsafe?
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Albright. Is any science-based practicing physician would know that there are credible bodies of research and evidence and literature that are constantly evolving and changing in terms of best patient practices and the efficacy of certain treatments for certain conditions. So as those change, and a health plan evaluates the most contemporary research pertaining to the efficacy of certain drugs for certain conditions, if a health plan observes that and reflects upon it and then reevaluates its formulary composition based on that, I think that that's a reasonable window of flexibility to allow them.
Representative Albright.
Thank you, Madam Chair. So if I did my own research and posted it, deemed it credible, could I affect a formulary?
Representative Cantrell.
If under your response, am I a credible source?
Representative Cantrell.
Thank you, Madam Chair. Thank you, Representative Albright. I don't think you would be an independent source of research if you publish your own research and deem it credible.
Representative Cantrell, I think the point being is that you're not defining what an independent source of research is here. You have no basis here to say what is credible or not. It just specifies independent source of research. So at your own peril, I think you go forward with that language. Final question, Madam Chair.
Representative Albright.
In your House File 1257 as it's written, what effect would your legislation have on private contracts?
Representative Cantrell.
Thank you, Chair Moran, and thank you, Representative Albright. You know, I might have to defer to research on that.
Mr. Chu. John.
Madam Chair, Representative Albright, if by private contracts, do you mean contracts between an enrollee and their plan of health coverage?
Yes.
Well, I think that this bill would function as, I guess, many other proposals to change what's covered or how something is covered. I think that when plans, put together their formularies, or when plans put together documents maybe explaining how formulary changes are made during the year, I think these types of things would be incorporated into those contracts.
Madam Chair, if I could ask a follow-up to Mr. Chun.
Okay, Representative Albright.
Thank you, Madam Chair. Mr. Chun, would that also affect private contracts between HMOs, PBMs, insurance companies, and HMOs, or the triangulation of those three entities?
Mr. John.
Madam Chair, Representative Albright, I guess the duties for compliance here are placed on the health plan company. So I guess the health plan company, when it does, say, use the services of a PBM, I think it would have to ensure that the PBM, was following provisions such as these, because it would be the health plan that has, sort of ultimate responsibility for compliance.
Madam Chair?
Okay.
Thank you, Madam Chair. Final question, Representative Cantrell, we're in the midst of talking about changing policy for the benefit of enrollees to formularies midstream, but yet in your effective date or date of enactment on here, it would seem that you are changing course with regard to enrollees midstream because there's no effective date here as well. It would be effective the date of enactment by default, or July 1st, August 1st?
Yeah.
Mr. Chun.
Madam Chair, Representative Albright, the default effective dates when an effective date isn't specified in the bill is either August 1st in the case of a bill that doesn't have a cost, or July 1st if the bill has a cost.
So Representative Cantrell, I would coordinate that enactment so that you are consistent with the language in the bill.
Representative Pearson.
Thank you, Madam Chair, and Representative Cantrell, thanks for bringing the bill. I understand the intentions. And actually, Representative Bonner's line of thought kind of just triggered it in my head that, again, we have a lot of testifiers who are negatively impacted. And again, maybe someone else wants to speak to this, but when we have those individuals that are negatively impacted, I just wonder if there is the potential there that thousands of other people are actually benefiting from these changes that are occurring. Whether that's in the price of the prescription drug that's being given at that point, or again, there's adverse reactions to medications. That happens, right? And while the change in the formulary for the PBMs might be negatively impacting one person and costing $10,000 for the hospital visit, and only saving $1,000, that's going on for 1,000 people or 10,000 people, and the rest of them are having positive outcomes, and we're lowering the costs of that total cost of the delivery of health care. Within the exceptions that you've given, do we still have that flexibility for those changes?
Representative Cantrell.
Thank you, Chair Moran, and thank you, Representative Pearson, for your extremely thoughtful question. I believe that this does still provide a great breadth of flexibility, and contrary to some of the testimony that was heard in this committee hearing for this bill, this doesn't restrict health plans from changing their formularies. It still allows for that, and it has several enumerated conditions under which health plans are able to alter their formularies. So I think that it still allows for a health plan to participate in the health economy without having to serve at the detriment of patients. And I think effectively it seeks to and will be successful in remedying this current ongoing problem that we've heard from a lot of advocates from across the board, whether they're struggling with diabetes or epilepsy or any other type of chronic health condition that requires continual and very specific healthcare maintenance. So I absolutely appreciate your question and making sure that somehow the language in this bill doesn't disadvantage some people at the benefit of others. And I think that we have avoided that with the language in this bill as it's currently written.
Representative Pearson.
Madam Chair, could the author just point me to where those exceptions are actually provided? Because I'm just seeing in subsection 3 of, I guess this would be
Representative.
Looking at section 1, subsection 3, is that what I'm looking at? Subdivision 3?
Madam Chair, Representative Pearson, so in subdivision 3, let me just take a look at this really quick. Subdivision 3 outlines formulary changes, and so it's pretty much from lines 2.12 to lines 2.32. We're outlining a lot of those different components that I expressed in my statement.
Okay.
Madam Chair.
Representative Pearson.
Well, so I see where, D is obviously, that's a no-brainer. If it's, the FDA has deemed it unsafe, we're going to let them drop that drug, right? But sections B and C then are what's going to cover the type of formulaic, you're saying that language is what's going to cover us for the type of circumstance that I was describing earlier. I guess I don't know if someone else can comment on that too, because I just don't know that that's giving us quite enough latitude for those entities.
All right, thank you. And please introduce yourself and who you're with and proceed with your testimony.
Good afternoon, members of the committee. Eric Dick with the Minnesota Medical Association. Thank you for your question, Representative Pearson. I would point you to the language in paragraph C, beginning at line 2.23, specifically the language following the last comma on line 2.25, provided that these changes do not apply to enrollees who are currently taking the drugs affected by these changes. This is language that we at the Medical Association pursued with Representative Cantrell because they allow health plans maximum latitude to change formularies, save for those instances when a patient is currently taking a drug and that drug therapy is working. Under this bill, health plans would be allowed to change formularies as they see fit, save for those patients who are currently taking a therapy that's working for them.
Okay.
Well, Madam Chair,
Final question? Maybe?
I don't know. To me, that just goes to, it poses that entire concept of, yes, there are adverse reactions to drugs and changes, but sometimes people are just taking the medication per what their doctors are ordering, and these formulaics could change and actually improve their lives. And here, you're basically making the statement that can only happen at the anniversary, on January 1st when that new plan comes out. And I don't know. Again, a doctor's going to be making the changes. Along the way if someone's having a negative reaction to their current prescription, one would hope and assume. But here we're just so narrowly giving anyone the opportunity to make those changes. And I kind of ask the question, if we anticipate the costs are going to go down by thousands of dollars for thousands of patients, and yeah, there might be a couple of adverse reactions, not to be cruel about it, because of course we want to make sure the patients are safe, right? We're not trying to prescribe anything that's unsafe for them, but this concept of a penny wise and a pound foolish, there's a whole calculation to that if there's enough pennies adding up there, it may not hold true that that's the right decision. And this gives very little latitude as I read it, because we're saying if you're on a drug and things are good, there's no way they can change it. And again, that's maybe what we all feel the doctor's job is, but here we've got this management company that has that responsibility, and we're really tying their hands as I read the language, because it's giving very little narrow exceptions for that.
Representative Noor.
I'll pass.
Okay, Representative Bonner.
Thank you, Madam Chair. Representative Cantrell. So we talked a lot today about do no harm. I think our first testifier came up and said, well, the intent of the health plans is certainly to do no harm. Well, I have to be honest with you, switching drugs midstream to have someone end up in the hospital is certainly doing harm. Not to mention, just to be clear, when I mentioned earlier that the average hospital stay is $10,000, that's an average. That's an average. That doesn't mean it's not more. And if, let's say, you switch a patient to another drug or another insulin, for example, that does not work, and they end up in the hospital, because the other drug they were taking before is still not on the formulary, they're going to try yet a third drug. And what happens when that drug fails, which, by the way, happens and has happened, then they end up in the hospital again. Now we're at $20,000 to save a few pennies. That math doesn't add up. It makes no sense. Quite frankly, and I'm really disappointed we're not having this on a day in which Dr. Mann is here, because I can tell you that she will be the first one to stand up and raise her hand and say that doctors, and I'm sorry, we have a doctor in the corner, but the point here is that we have to do what's right for our patients, right? And that means on every level. And every doctor will tell you that most patients, in many cases, have tried and failed, and we'll let the doctor speak to this, but, you know, have tried multiple medications. And when you find something that works, you want to keep your patient on it. You want them to have the best possible health outcomes. So arbitrarily switching things willy-nilly makes no sense. And I would think that the doctors would take certain exception to the idea that they are simply prescribing a drug just because that's what they're prescribing, and that they could just go ahead and switch things willy-nilly based on changes. I don't think most physicians would be okay with that concept, which is sort of what was implied here. I really think there would be a real exception to that. And not only that, you know, just to bring this back to the whole point we're here today, this is about making sure that consumers have transparency. They sign up because they're using a drug that works for them, that is consistent, that helps ensure their health. They've worked with their physicians, hand in hand, to find that drug that works for them. And when they are using that as the basis of their decision to enter into a contract, they have a reasonable expectation that the other end of that contract will be fulfilled. Plain and simple. Thank you.
Chair Liebling. Thank you, Madam Chair. Sorry, I just would like to respond to a couple things that have been said here. Ms. Commit, I think, said to us that that pharmaceutical costs are a big part of what's driving increases in health care. And granted, they are very important. Drugs are very expensive. And that this tool that they use through the PBMs to keep costs down, this is a cost-saving thing. Representative Pearson was, I think quite rightly thinking about what's the overall impact on patients. But I just want to remind folks about something else, that we've been told that if we stop subsidizing health insurance companies to the tune of hundreds of millions of state dollars, that they will increase rates by, I think it's 54%, that rates will just shoot up. So my question is, where's the big cost savings here? If this is indeed, they're balancing things out, and as Representative Pearson, I'm sorry he left the room, but if things are being all balanced out, as he's suggesting they might be, why in the world then would they be saying that their rates, and frankly, I don't believe them for a moment that that's what will happen, but that is what they are claiming, that rates will just shoot up. And so that would tell me that these strategies they're using are failing miserably, if that is what indeed would happen, if we stop giving them hundreds of millions of state dollars to keep their rates down. So that is one thing. The other thing I wanted to point out, and if Ms. Commit, I'm not going to ask it as a question, but if she wanted to respond, I'm sure the chair might allow her to. But In another committee, as members know, there's another proposal, there are other proposals moving through, one of them from the governor, to have a separate prescription benefit and stop, in other words, right now, in our public programs where we're doing fee-for-service, the increases are much lower than they are in the prescription benefits under the HMOs that are using PBMs. Okay, so somehow, whatever they're doing with the PBMs is not working to keep costs down. I believe Ms. Commit made the comment that she was opposed, or her organization was opposed to pulling out this benefit, doing it separately, because it would really impact the ability of the HMOs to manage care, to coordinate care. But we also just heard her say, in response to some questions from Representative Loeffler, she doesn't even know how the PBM coordinates with the healthcare side, the other kinds of healthcare that these plans are managing. So I would just submit to members, I've come to understand over the years that what the HMOs are really managing is money, not care. And I am highly skeptical of the claim that this is, that doing this and being able to switch patients around willy-nilly is off of the medications that they were promised when they signed up for that plan, that this is a cost savings to the consumer, that it gets passed through to the consumer in any respect, because anyway, I will leave it there. I just think that it's been a very interesting conversation, and I am highly skeptical of the excuses that are being given to us, and I support the bill.
Okay, the next person will be Representative Newt, and then we're going to do closing statements.
Thank you, Madam Chair. Representative Cantrell, I wanted to focus on subdivision 2 on page 2, the prescription drug benefit disclosure. And I'm wondering if you can just briefly explain this section and how it might differ from current disclosure.
Representative Cantrell.
Thank you, Chair Moran. Thank you, Representative New. I just think it's a good section to have in the bill.
Madam Chair, thank you. Do you know how it differs? Do you know what current disclosure is and how this might differ?
Representative Cantrell.
Thank you, Chair Moran, and thank you, Representative New. You know, I got to say, I just think that this is a good section to include in the bill to make sure that it's linked in with the language of this piece of legislation.
Thank you, Madam Chair. So we don't know how this will change things. Then my next question, I will follow up and under C and lines 2.10 and 2.11, there are a couple of things that I'm wondering about. For each item or category in the formula, it says the benefit terms must be identified. I actually assume that, I could be wrong, but I would think that that's already happening. The next item says including enrollee cost sharing. And I'm wondering, I looked through the definitions in the bill, and it does not define the enrollee cost sharing. So I'm just wondering what specifically that is referring to.
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative New. So it is referring to the alterations that may occur in the share of essentially the cost sharing, the fluctuations in cost sharing, and expected out-of-pocket costs with any type of prescription drug in the formulary or any type of anticipated changes.
Madam Chair.
Representative New.
Thank you, Madam Chair. So this is specifically referencing the formulary at the beginning of the year, is my understanding, is it not? Or is this referencing formulary changes? Because my understanding is that they would not be allowed to change based on this bill. So you're talking about fluctuations. I'm just wondering, I'm not sure that definition is clear on cost sharing. And what you're explaining, I guess, is not sort of what I assumed it would be. So do you have a good or perhaps that's a better question for nonpartisan staff?
Actually, Madam Chair, I can answer that question. You can change the You can change the formulary, Madam or Representative New, in this bill. This bill language includes several sections that allows a health plan to change its formulary during the contract year. There are several exceptions in this bill that permit a health plan to change its formulary, including expanding its formulary by adding drugs to the formulary, shifting the drug to a different cost benefit tier, as long as that decreases the drug. So this is, in the bill, there is language that says you can change the formulary. There are several conditions under which that can take place.
Thank you, Madam Chair. Yeah, I do understand that. I guess what I'm getting at here is that this enrollee cost sharing is not defined, and it doesn't say here that it's the fluctuations that may be happening. It simply says the enrollee cost sharing. Now, I'll be honest, I assumed what that meant was that they had to clearly define co-pays, co-insurance, this kind of thing, but perhaps that's not correct. Is this based on something else?
Representative Cantrell.
Thank you, Madam Chair. No, no, Representative New, that is correct.
Thank you, Madam Chair. Then the next question, the very next piece there, the expected out-of-pocket costs. I'm wondering how that would be defined, expected out-of-pocket costs. Is that based on current prescriptions? Is that somehow forecasting your health into the future? How would expected out-of-pocket costs be calculated?
Representative Cantrell.
Thank you, Madam Chair. Thank you, Representative New. The expected out of cost would be calculated just as any other type of, in any other circumstance in which you are anticipating that there might be cost X out of pocket for drug Y, let's say. So that's pretty much what that is referring to.
Thank you, Madam Chair. So that would be based on each individual drug in the formulary, that expected out-of-pocket cost would be defined for each individual thing. It's not based on the patient, it's based on the drug in the formulary.
Representative Cantrell. Was there someone from the department that can respond to this, please? Thank you. Please reintroduce yourself.
Madam Chair, Representatives, Eric Dick with the Minnesota Medical Association. I'm sorry, Representative New, may I trouble you to repeat your question?
Yeah, absolutely. Thank you, Madam Chair. My question is, how are the expected out-of-pocket costs calculated? Is that calculated for each item in the formulary? Meaning, is it item-based or is it patient-based?
The intent, Madam Chair, excuse me, is to make it item-based. So each individual drug that's included on a formulary, the expected out-of-pocket cost would be calculated.
Madam Chair. Thank you, Madam Chair. And do you have an idea of how many items or categories are currently on a typical formulary? And is that information currently available, or would that be a change, really?
Madam Chair, Representative New, I believe, formularies are fairly readily available presently. At the MMA, we've done a lot of research into formularies and where they're parked on different websites. Some health plans make it very easy to find a formulary, some don't. Some take quite a bit of searching. So to your earlier question, the transparency piece included in subdivision 2 at line 2.4 we think is really important. I will plead a little bit of ignorance on what current law requires as a matter of transparency for formularies, though we believe that this language certainly makes clear that health plans cannot be hiding their formularies. They need to be readily accessible for consumers.
Thank you.
Thank you. So I had stated that we was going to go to closing statements from the author, but it seems like Representative Albright needs the closing statements. There you go.
Madam
Final
Chair, maybe not a closing statement, but I listened with great intent to Representative Liebling's statement, and I think there were some pretty provocative comments made in her dissertation, and I'm just wondering if I could request Catherine commit back to the testifiers table. I'd like to hear her response.
Ms. Commit. Ms. Commit, do you remember the question that Representative Albright is referring to, or Representative Albright, you would like to enlighten us on what the question was?
Thank you, Madam Chair. Ms. Commit, just in this committee provided a statement by Representative Liebling, made some, not assertions, but made some statements that certainly, I think, compel a response. Not that I agree or disagree, but I think it's in fairness, should be provided an opportunity to respond.
Ms. Commit.
Thank you, Madam Chair, and Representative Albright, Catherine Commit from the Minnesota Council of Health Plans. So while I was away from the table, I did get a chance to talk to a couple of my colleagues, and I'm happy to share with you that the health plans do get drug utilization information from the PBMs that they use to help manage the care for patients, but especially for people with complicated conditions, including people who are diabetic. I can also tell you that there is a benefit exception process that is available. So if a drug is working for a patient and they don't want to change it, and it's been worked out between the physician and the patient, there is an exception process in place to allow the patient to continue on that particular drug. And then one of my other colleagues informed me that one of the plans saved $5 million 1 year by just changing from one insulin to another one, because the cost of the drug is so exorbitant. They were able to save $5 million. And again, if somebody is on a particular medication, a particular type of insulin, they're able to stay on that or to go through that exception process along with their physician to help make that happen. And then I did want to just say, I'm going to testify on the next bill. I guess I'll leave my remarks till then, but with respect to carving out prescription drug coverage. So I'll be having comments there too.
Closing statements.
Thank you, Madam Chair and members of the committee. I would greatly appreciate your support. Thank you.
Representative Fiber.
Oh,
No.
no.
Go ahead.
I'd like a roll call on this, please.
Okay. All right. So a roll call has been called. The clerk will take the roll. So, okay. There being no further discussion, the chair renews a motion that House File 1257 be recommended for re-referral to the Committee on Ways and Means. The clerk will take the roll.
Chair Moran.
Yes.
Vice Chair Morrison.
Yes.
Minority Lead Keel.
No.
Representative Albright.
No.
Representative Backer. Representative Bonner.
Yes.
Representative Edelson. Representative Fisher. Representative Freiberg.
Yes.
Representative Liebling.
Yes.
Representative Loeffler.
Yes.
Representative Mann. Representative New.
No.
Representative Pearson. Representative Pinto.
Yes.
Representative Robbins.
No.
Representative Schumacher.
No.
Representative Schultz.
Yes.
So there being 8 yes and 6 no, the motion prevails, and House File 1257 is recommended for referral to the Committee on Ways and Means. Our next bill up is with Representative Cantrell, 1523. The chair moves House File 1523 to be recommended for re-referral to the Committee on Ways and Means. We have the bill before us, committee members. Representative Cantrell, please present your bill.
Thank you, Madam Chair. Thank you, members of the committee. It's a pleasure to present to you today House File 1523. House File 1523 is a bill that would establish a unified pharmacy benefit, or excuse me, a unified pharmacy program for public health benefits through the Department of Human Services for all Minnesotans enrolled in medical assistance or Minnesota Care, and for Minnesotans who purchase health care coverage from participating plans through or off MNsure. Through the program proposed in this bill, the state would be able to have a greater purchasing and negotiating power with pharmaceutical manufacturers that would additionally yield cost-saving benefits. Over the past few years, we have not seen a dramatic increase in the cost of coverage for individuals enrolled in fee-for-service public health benefits, whereas from 2015 to 2017, the cost of administering managed care plans has increased 21.5%, largely because of increasing pharmacy costs. All of Minnesota's managed care plans subcontract with pharmacy benefit managers, and this bill seeks to expand the cost savings already being experienced in the administration of fee-for-service public health plans, for which the state is already negotiating prices and leveraging purchasing power, to the administration of managed care plans as well. As a result of the public processes that are employed for the purposes of this program, will be employed by DHS. This program will be significantly more transparent than the opaque process through which pharmacy benefit managers operate and price their products, as well as in terms of how pharmacy benefit managers and health plans currently interact with the whole landscape around rebates. Both pre-authorization criteria and preferred drug lists will be publicly posted, and the overall rebate incentive structure, being devoid of profit incentives, will result in greater cost savings for patients. I do want to say that the state of West Virginia implemented a program similar to this one, anticipated saving $30 million. They ended up saving $38 million. So this is not a novel concept. We are already doing this for folks who are on Medicaid. What this bill really does is it expands the amount of potential covered lives, and it expands the state's leveraging or purchasing power and negotiating power in driving down the cost of pharmaceuticals. To understand the scope of this bill, there are 1.2 million Minnesotans receiving health care coverage through medical assistance and Minnesota Care combined, which roughly translates to 1 in 5 Minnesotans total. By streamlining the administration of prescription drug benefits for all individuals who qualify as eligible enrollees through this program, we as a state would not only be able to ensure that more people, especially those who are the most vulnerable among us, are able to afford their essential medications, but we would also likely drive down significantly the cost of administering prescription drug benefits for our public health programs. I will say that this bill is a starting point. This bill has had one committee stop so far. It stopped in Commerce prior to arriving in this committee. And there are a lot of things that DHS and I are working on to refine certain elements of this bill. And especially as we compare it to Governor Walz's One Care package, we're looking at the various options, and that's what this whole legislative process is about. It's about having various options and exploring what works best to serve the folks of Minnesota. So as we continue working to evolve its technical framework, I greatly appreciate any feedback from members of the committee, and I know that folks from DHS are in the room to answer solely technical questions about this piece of legislation. And with that, I will include also that the Minnesota Nurses Association also supports this measure. And with that, Madam Chair, I yield for questions and I ask for folks' support.
Thank you, Representative Cantrell. You have one, there's one testifier, Ms. Commit. Welcome back.
Thank you, Madam Chair and members of the committee. Catherine Commit from the Minnesota Council of Health Plans. So I hope my comments will get to some of the questions that Representative Liebling was raising earlier. House File 1523 is the governor's proposal to carve out the prescription drug benefit. Oh, I see Representative Cantrell is shaking his head. Let me rephrase that. Is a similar proposal to what the governor has recommended to carve out the prescription drug benefit from health plans for people covered through the state public programs. We strongly oppose carving out prescription drugs because it will make it much more difficult to coordinate care for our members for related health conditions. DHS, through their contracts with the health plans, has moved to a state-based preferred drug list. This bill goes a step further by carving out prescription drugs altogether from health plans. Carving out drugs assumes that the state can achieve something that the health plans cannot achieve. We don't understand that assumption. From a quality standpoint, the drug carve-out will disrupt coordination of care, create multiple customer service points for members, and take away the health plan's ability to truly manage the patient holistically. Lack of care coordination will have a negative impact on patients and their health. We also note that the prescription drug questions that health plans receive generate a significant volume of calls from members, and we question whether DHS has the capacity to handle a potentially large volume of calls from enrollees from government programs as well as the individual market. Given some of the proposals before Congress and recent executive actions proposed by the current administration, we feel it is not appropriate for the state to be moving in this direction at this time. We respectfully oppose this bill. Thank you.
Thank you. Is there anyone else in the audience who wishes to testify on House File 1523? Okay.
I'll be brief, Madam Chair, members of the committee. My name is Sarah Greenfield, representing Take Action Minnesota, and I just wanted to point out that you have testimony in support of this bill written in front of you, along with a report from Altram about a poll conducted just last year that shows the need for this bill. So we ask for your support.
All right. Thank you so much. Okay, any discussion? Representative Albright.
Thank you, Madam Chair. Representative Cantrell, in your definitions, I see that you are identifying the people that would be eligible for this program. Could you identify in terms of the number of enrollees, both in medical assistance and Minnesota Care, that would be considerate under your proposal?
Representative Cantrell.
Yes, Madam Chair, and thank you, Representative Albright. So currently, I know that the combined number of MA or folks enrolled in MA in Minnesota Care is 1.2 million Minnesotans, and I could ascertain the numbers in the further breakdown of that for you. As for folks currently enrolled in MNsure, that would be around, I think, 100,000 or so. But otherwise, I can get more specifics on those exact numbers. But we know that 1 in 5 Minnesotans are either enrolled in MA or receive health care through Minnesota Care.
Representative Albright.
Thank you, Madam Chair. Representative Cantrell, on page 2, lines 19 and 20, you identify that the commissioner may contract with one or more entities to perform any of the functions described in paragraph A. So would this construe that they could contract with a PBM for the services that you espouse to in the bill?
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Albright. The goal of the program is to reduce the overall cost of care, and seeing as the state would be unlikely to do that, I doubt that they would take such latitude with the language written in this bill as to contract with a for-profit pharmacy benefit manager.
Madam Chair, Representative Cantrell, so how does the commissioner and his department anticipate going about doing this work? Is this, what department would it undertake? And I'm wondering if they have the capacity, and have you discussed this measure with the commissioner? What are his thoughts on this?
Representative Cantrell.
Thank you, Madam Chair. Thank you, Representative Albright. This bill is actually modeled after a bill that the commissioner introduced a few years ago. And I actually have, from the very beginning of this process of putting this bill together, I have been talking with DHS to make sure that it is consistent with their capacities and consistent with their operations. So all of the involved entities have been consulted about this. I haven't asked Commissioner Laurie exactly what his thoughts are on this bill, but since it's modeled after a bill that he introduced, I would assume that he would let me know if he took umbrage with it, but perhaps I could be incorrect there. But however, I have been talking with DHS, and they have indicated that that this bill is not only feasible, but it doesn't. It's not outside of their capacities. Especially, pardon me, Representative Albright.
Go ahead.
Especially because is a state government already administering these public benefits. So this would essentially be a lateral expansion of the practices that are already being employed at the state level.
Representative Albright.
Thank you, Madam Chair. Representative Cantrell, under lines 25 and 26 of page 2, you also note that a federal waiver will be necessary to move forward with this. I'm just wondering what waiver you are discussing and whether or not that process, how long it would take, and what measure would be undertaken if not, if the waiver was not received.
Representative Cantrell.
Thank you, Chair Moran, and thank you, Representative Albright. So in the language in particular, the Commissioner shall seek any necessary federal approvals to implement this section. The point at which we are currently, we don't know if any waiver would be necessary, but should one be necessary, it would be my assessment that a 1332 waiver may need to be pursued, but we're a little bit out from evaluating whether or not the federal government would require us to submit any type of waiver request for federal approval. There are some components that may require approval, but we are currently working on what that might look like and if that is actually the case.
Madam Chair, Representative Cantrell, I think Massachusetts did require and did understand through CMS that the 1332 waiver was required, so best prepare for that. Madam Chair, Representative Cantrell, have any health plans expressed interest in participating in this program?
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Albright. There's only been one health plan lobbyist who has approached me about this, who has expressed disinterest about this. However, I think that as conversations pertaining to the possibility of this program continue, I think that health plans would really do well to take a look at, in the interest of competition in the free market, to take a look at, well, if we can reduce prescription drug costs, as Ms. Clem said, was a huge concern of theirs, if we can reduce prescription drug costs by pursuing this program, well, then that might be an avenue that's worthwhile pursuing.
Final question, Madam Chair, Representative Cantrell. Obviously, this is going to require funding to maybe to counter your assertion that DHS may be able to take care of this within their own budgets. But did the governor in his budget proposal consider or put forth any type of appropriation for this type of language?
Thank you, Madam Chair, and thank you, Representative Albright. Yes, and then there's also an anticipated cost saving going back to those figures that I cited in my opening remarks about how for the fee-for-service public pharmacy benefit, costs have remained fairly stagnant related to pharmaceutical costs, whereas for managed care organization costs, we've seen a 21.5% price increase. So we're also anticipating, well, yes, there is a portion of his budget that pertains to an idea like this. And while there is going to be some transition costs, and there's always some costs with getting things running, we're also anticipating a greater proportional savings as a result of just that discrepancy in those two figures that I just mentioned.
Madam Chair, so are you asserting that there's going to be some type of a enterprise fund necessary for reserves to be held in while this plan is put together?
Thank you, Madam Chair. Thank you, Representative Albright. You know, I'm not certain yet. I'm not certain yet whether or not an enterprise fund would be necessary.
All right, so we have an amendment before the body. So Representative Cleveland moves the A1. Representative.
Yeah, thank you, Madam Chair. I would like to move the A1 amendment. Members, this is something that, actually, I'm doing this on behalf of Representative Mann. She has introduced a bill to this effect, but frankly, we wanted this to meet deadline. And it's really just a clarification to current law. And this relates to the fact that, as you all know, some pharmaceutical manufacturers have these special programs to assist some consumers. Of course, we could probably debate whether the overall effect of those plans is, how beneficial that is on drug prices. But the bottom line on this is that there are some constituents around the state in several members' districts, as a matter of fact, who are benefiting from these programs. But there's a clarification needed because some of the drugs that are being provided need to be administered with certain very expensive supplies. And so all this does is clarify language that would allow those supplies to be provided in addition to the drug itself. So it really is just a clarification to current law that's been requested by certain manufacturers who feel that they would provide this but aren't able to because they just don't want to run afoul of our law in doing so. So we would appreciate your support in attaching this to the bill and letting it get a hearing so that we can move it along.
Madam Chair.
Representative Cantrell, one moment. Do you have any comment to the amendment?
Thank you, Madam Chair, and thank you, Representative Liebling. This is a friendly amendment, and I urge members' support.
Madam Chair.
In discussion, Representative Albright.
I'm sorry. Thank you, Madam Chair. You know, I'm a bit in a quandary because I'm looking at the section of statute that the bill pertains to, 256B.86, but yet in the amendment, the statute that is clearly in this bill is 62J.23, and I'm just wondering what relevance this amendment has to the underlying bill.
Madam Chair. Thank you, Madam Chair. Well, Representative Albright, there's no germaneness rule in committee. So both of this bill, Representative Cantrell's bill, is being recommended to be re-referred to Ways and Means. It's from there, the expectation is it would be referred to the Health and Human Services Finance Committee, where it would be laid over for possible inclusion. So, you know, whatever is attached to it, whatever barnacles it has on it, they're going to come off at some point. So the relevancy, the germaneness in committee, there is no germaneness rule in committee. And, you know, over the years, I've watched many, many members on deadlines move language in this way. So that is frankly what we're doing. We are not claiming it is germane to the bill, other than that this is a bill having to do with pharmaceuticals.
Representative.
Representative Albright.
Thank you, Madam Chair. Representative Liebling, I mean no disrespect on issues of germaneness. I just noticed that for purposes of clarity, we are dealing with two different sections of statute, and to the extent that we both, or committees have certainly participated over the years that I've been here in using couriers or carriers or chassis to bring about other pieces of legislation, we know how this establishment works. So just a point of clarification, just to make sure that we're all aware of what's going on here. Thank you.
All right. Any further discussion on the amendment? If there's no further discussion, all in favor of adopting the A1 amendment, say aye.
Aye.
All opposed? No. The motion prevails. Okay, so there've been no further, the amendment is adopted, yep. Yep. So being no further discussion, the chair renews her motion that House File 1523 as amended be recommended for re-referral to the Committee on Ways and Means. All in favor, say aye.
Aye.
All opposed?
No.
The motion prevails, and House File 1523, as amended, is recommended for re-referral to the Committee on Ways and Means.
Thank you, Madam Chair, and thank you, members of the committee, for a wonderful and lively discussion.
Okay, next up is House File 1719, Representative Noor. Okay. The chair moves House File 1719 be recommended for re-referral to the Committee on Ways and Means. We have the bill before the committee. Representative Noor, I understand you have an author's amendment, and the chair would like to entertain a motion of the A1 author's amendment. So moved. Chair Liebling moves the A1 author's amendment. All in favor say aye.
Aye.
All opposed? The motion prevails and the amendment is adopted. Representative Noor, please present the bill.
Thank you, Madam Chair and members. House File 1719 removes some provisions for participants who are receiving MFIP, which is Minnesota Family Investment Program, and general assistance. The requirement for drug testing, and also the exclusion for individuals who, subsequently found that they have used some drugs. So this bill establishes a process whereby the county will be required to do a referral and allow the individual to get the help that they need. We all understand the challenges that we're facing with the opioid crisis, and we want to make sure that we're allowing the individual to have the services that they need. Essentially, this provides a process for the individual who is a participant to get what is required. Also, it also removes the sanction, which is almost 30% for individuals who are receiving MFIP. I have a testifier who's here to walk us through the bill.
Yeah, thank you, Representative Noor. Please introduce yourself for the record, who you're with, and proceed with your testimony.
Thank you, Madam Chair, members. My name is Jessica Webster. I'm a staff attorney with Legal Aid. We're here in support of this bill, and we thank Representative Noor for carrying it. What this bill does, it does not repeal drug testing. It does not remove drug testing. It does restore discretion to counties on doing drug testing in our public benefits programs. And as Representative Noor said, it removes the sanctions that can happen if someone shows signs of chemical dependency or substance use disorder. This session, Legal Aid has been testifying in support of all of the opioid legislation that has been moving forward. And we've been doing that because we believe that the state is now in a different place in the conversation about substance use disorder and chemical dependency. But in our testimony, we've been noting that there is this area of law, this section of law, where a handful of years ago, the legislature decided to get tougher on people who had chemical dependency issues and were accessing public benefits programs. So we wanted to make sure that existing law for families with children and for vulnerable adults who are accessing very small amounts of assistance in Minnesota, we wanted to make sure that they are treated in the same compassionate way that we are now looking at treating other populations that are dealing with these crises. So what a sanction looks like, for instance, in the Minnesota Family Investment Program, a family that's receiving a $348 a month grant could have a $300 sanction. So their grant would be cut by $300 if they showed signs of illness. And this is not a huge number of people. This is a very small number of people that we're seeing that have tested positive in these programs. But this would be a way to make sure that we have a compassionate response. It doesn't require the county to pay for treatment. It doesn't require the county to do anything extraordinary other than provide resources and referrals to folks who show those signs of illness. Thank you for your support.
Thank you so much for your testimony. Representative Robin.
Thank you, Madam Chair. Thank you, Representative Noor. I just have a couple questions. So you mentioned that currently this applies to just a small number of people who would be failing the drug test. Do you currently track those numbers, and are they reported to the legislature?
Ms. Webster.
Madam Chair and Representative, I have seen those numbers. DHS does keep that data. We saw them recently. I believe it was fewer than 100 individuals, but I would defer to them on how many people out of, that'd be 30,000 families in the Minnesota Family Investment Program, and probably, I won't say it, some thousand numbers of general assistance.
Thank you.
Representative Robin.
Thank you, Madam Chair. And do you think that one of the reasons for the low number is the deterrent effect of people knowing that they would lose their benefits?
Ms. Webster.
Madam Chair, Representative, I don't quite understand your question.
Representative Robin.
Madam Chair,
Noor.
I've been, working at the county for a long time, and I have issued MFIP benefits. And quite frankly, what I've seen is that number has always been low, no matter what, whether we had the drug testing or not. But DHS individuals can, guide us in the process, because this allows individuals who have been convicted to still receive the benefits with some conditions. It does not remove that, but it also allows the county to also collect data from the treatment codes so that they can really evaluate if an individual is receiving, benefits and is using some drugs. So the system is already working. But the issue right now is if somebody falls through the crack, we're going to sanction them. We will be punishing them because they did not get the right services. So essentially, this bill allows individuals to get the services needed for treatment and making sure that we're taking care of those children and families at the same time.
Thank you, Madam Chair.
Representative.
And I appreciate that, and I support that intention. I'm just concerned that if the county is not paying for treatment, and they're just referring people, perhaps they won't be getting the treatment they need. And so how would we track that? How would they get the treatment? And then also, if there is no treatment and they continue to receive the benefits, I just wondered if we would also get tracking on those numbers, if there's any change in how many people do fall in this population, and we could see if there's any effect of this bill on that number. Thank you.
Ms. Webster?
Madam Chair, Representative, I think that would be a good step, and I think that if there were the political will to provide investment for more treatment beds and more treatment and resources across, especially greater Minnesota, we would welcome that.
Madam Chair.
Representative Robbins.
I'm sorry. So, but as it stands, this will just say they continue to receive the benefits and get referred to treatment, but there's no requirement that treatment is taken as a condition of continuing to receive the benefits, and there's no further sanction. Is that accurate?
Ms. Webster?
Madam Chair, Representative, that's accurate, and I think what you're seeing here, this is a first step in terms of making sure that folks have housing and food and some very rudimentary basic needs. One of the folks that we worked with this summer was a gentleman from Bolus, Minnesota, who had been working as a handyman and had lost work and had been clean for several years and relapsed, and he received a $203 general assistance grant. And when he relapsed, he failed the test and he lost the $203 grant. And he was renting a room in Bolus, Minnesota for $200 a month. So all of a sudden he was homeless, and Legal Aid is then looking for, frankly, more expensive options, group residential housing or other alternatives for him, rather than letting him rent that room and hopefully get treatment, but at least be stably housed and have food in the meantime.
Thank you. Does any other Representative Noor?
Thank you, Madam Chair, and members. Representative Noor, you mentioned that that the number of, presumably, I guess I should ask, you said that the number has always been low with or without the requirement for drug testing. Are you saying the number of drug users has always been low?
Representative Noor.
Thank you, Madam Chair. Representative Noor, the number of people who are participating in the program who have been convicted of drug, but I will defer that to DHS if they have the exact numbers.
Welcome to the committee, and introduce yourself and who you are, and proceed with your testimony.
Thank you, Madam Chair. My name is Ryan Johnson. I'm with the Minnesota Department of Human Services. Representative, to answer your question, on calendar year 2016, the Minnesota Family Investment Program, there were a total of 42 people that were subject to drug testing, and 11 of those people tested positive.
Representative Noor.
Thank you, Madam Chair. And how often is that drug testing taking place with those 42 people? You said 11 tested positive. Is this happening periodically? Do they know when they're going to be tested? What's the procedure on that?
I don't have that information in front of me. Sorry.
Mr. Johnson.
Madam Chair, Representative, I don't have the procedure information on me right now. That is for the full calendar year, though. That those 42 individuals, that only 11 of those that were subject to the test actually tested positive in the full year.
Madam Chair.
Representative Noor.
Representative Noor, the what I understand from some of the counties, they use the drug treatment information so that they can understand if the participants are actually using drugs. And the second piece is some of them require them to do the drug testing based on this law right now. Every time that they come for recertification, by the end of the year, every 12 months, they do have a recertification. And there's a process and procedures that are in place to make sure that the drug testing is done.
Thank you, Madam Chair. So we're hearing a lot of numbers thrown out, and so I just want to be really clear on what's happening. One number we were told is that there are 30,000 people who are receiving the benefits, and that 100 of the people tested positive. So I'm just wondering where all of these different numbers are coming from. Of the 30,000 people receiving benefits, are we saying that only 42 people have been convicted of a drug-related offense?
Mr. Johnson.
Madam Chair, Representative, in calendar year 2016, that is correct.
Wow.
Chair Lieberman?
Well, thank you, Madam Chair. And I just wanted to say that I appreciate that Representative Noor is bringing forward this bill. This comes at a context of a lot of discussion we've been having in this legislature over several years about how we now understand substance abuse disorder. And what we've done in the past is take a punishment approach. We now understand, I think more fully than before, that what we're talking about is a chronic disease. Also, we have to really put this in context of what these programs are, and I think Ms. Webster mentioned it a little bit when she talked about general assistance and how much that was in the case that she talked about. But in the Health and Human Services Finance Committee, we had an informational hearing about the MFIP program, and I get the committee is confused, and I'm not sure how much we've talked about that in here, members, but it's really, really quite shocking how little these families are getting, how little they're living on, and most of the people in this program, I think it's about 70%, are children. So here's what we're talking about. This program very often functions as unemployment insurance for people who are the lowest wage workers, the people who are working retail, the people who are working fast food, who don't have unemployment insurance. And when they lose their job, this is the only place they have to land with their children. You have to have children to be on the MFIP program, right? So when people have a substance abuse disorder, what are we doing under current law? We are punishing them, and more importantly, we are punishing their children by taking away this extremely minimal level of funding that they now receive. We do have a proposal from the governor. There are member proposals before us this session to try to raise the cash benefit for these families. But I am really grateful that we are talking about removing this. I agreed with Representative Robbins was talking about needing to make sure that treatment is available, and we're trying to do that as well on a number of fronts, not for these families so specifically, but you know, this is a huge problem in our state, making sure that people can actually access treatment when they need it and get in there and take advantage of that. And I would like to see if we could get to it a more, sure way of knowing that these families, that if someone tests positive, they're going to get this service. But in the meantime, what we've been doing by punishing people to get them to stop being addicted, you know, if somebody's a diabetic, we don't punish them to get them to stop being a diabetic. If somebody has multiple sclerosis, we don't punish them to get them to stop. Now, I do know that, you know, these are diseases of denial. Sometimes, you know, there are different ways that this needs to be approached. But the idea that we're punishing families by taking away this very, very low subsistence level of help that we are giving them is just, it's both inhumane and it's ridiculously out of step with our understanding of substance abuse disorder or substance use disorder. So I applaud you, Representative Noor, for paying attention to these issues and to Ms. Webster, who works on this tirelessly. And I certainly hope we can do this session. Thank you.
Thank you. Representative Loeffler.
Well, thank you, Madam Chair. And Representative Noor, I appreciate your bringing this forward and bringing us to an approach of supporting families who need help in tough times. And we know there aren't enough treatment facilities, particularly those who will take women with their children so that the family can stay together. There's often a wait time. To say during that wait time that the food support for that family, the food that is used to feed those children should be cut, to say that the grant should be cut so that they could potentially end up in a shelter that can cost as much as $2,000 a month, but more importantly is just totally devastating to those children. Education studies have shown that when they get into that situation, they are just so overwhelmed and traumatized that their educational progress stops until that family is restabilized. And that is just too heavy a burden for someone who is trying to stabilize their life, maybe waiting for treatment, and is doing the best that they can. And the role of our counties and the role of our service system should be to help people, lift people up from whatever their health challenges are. We don't do this to the senior who says, I can't afford the co-pays and cuts their pills in half. We don't say, well, we're going to cut you off of some of the basic supports that you need. And I think we shouldn't do that with families and other people who are in the system because they know they need help and support.
Okay, Representative Albright.
Thank you, Madam Chair. Representative Noor, thank you for bringing this forward. I think this strikes a good balance between, as Representative Liebling and others have said, in terms of providing treatment, but also making sure that people are diligent about personal responsibility. I understand that the rule has been suspended for amendments, Madam Chair, and so I'd like to offer an oral amendment at this time.
Okay, the oral amendment has been offered. You want to speak to it?
Thank you, Madam Chair. And I will delineate it's just a change of one word for another. And so on lines 1.15, replace the word may with must. On line 2.11, replace the word may with must. On line 4.10, replace the word may with must. And on line 4.22, replace the word may with must. And my strong recommendation for acceptance of that is to the very point that I don't think it's voluntary for people to fall into a corrosive disease such as what Representative Noor has articulated. And I think it is incumbent upon us to send a strong statement in terms of our desire to get them into treatment and to provide the types of services that either the state or the county can offer to those individuals. So I would hope that the author of the bill would accept this as a friendly amendment.
Representative Noor.
Madam Chair, I will accept that as a friendly amendment. Just wanted to get clarity from House Research. Is it shall or must? Which one do we go with?
Ms. Pinelli.
Madam Chair and members, I believe the revisor's office typically does prefer must over shall.
I will accept the amendment from Representative Albright. Madam Chair.
All right, thank you. Chair Liebling.
Thank you, Madam Chair. And, I appreciate the sentiment here. I have to say, though, I think that this imposes an unfunded mandate on counties, and it looks like a pretty big one. I mean, it would be great if we could fund this and all of that, but just changing the language right here and now, I don't know if there's a county representative here or someone from DHS would want to address that, but it looks to me like an unfunded mandate on counties. Now,
Madam Chair,
the bill is coming, the bill is going to move on and go to HHS Finance, and I suppose, we can get a fiscal note on that. But I think that to just, well, maybe we should hear from the testifier about that before we just go mandating things, because I don't know about you, but I hear from my county all the time, don't put stuff on us, because, if you're gonna tell somebody to do something, you better find out, who's gonna have to do the work and where the money's gonna come from, and I will be severely chastised if I do not pay attention to that.
Madam Chair, and I would just articulate to add on to what Representative Liebling just said, that this is a policy committee, not a finance committee, and I'm certain that it would obligate a fiscal note, and that would be taken up in her committee as well as others going forward. But I think the sentiment or the intent of the bill is good. We're strengthening the language so that the people that are most in need of it will get it.
Would you like to speak to the amendments? Please introduce
Yes,
yourself.
thank you, Madam Chair. My name is Elizabeth Emerson. I'm the Vice President of Government Relations for Goff Public, and I'm here today representing the Minnesota Association of County Social Service Administrators, or MACSA. To the policy question, I think we would echo some of the thoughts that Representative Liebling shared, but to the policy of it, just kind of reading this, I think even in order to determine what the fiscal impact to counties would be, we would need definition around what the term resources means, and kind of what the scope of that means. Does that mean the county is actually administering those services, or as a referral suggests, we are referring to outside providers? So in order to even determine the fiscal impact, we would need some more policy definition around the term resources.
All right, thank you so much. Representative Morrison.
Thank you, Madam Chair. I would suggest using language that the county must provide referrals, and then we can re-examine the must provide resources as a separate issue.
Would you like to speak to that, Representative Noor, or?
Madam Chair, I think the requirement for the counties, as you have already had, must provide that resources. We've talked about the unfunded mandate, so I think I will defer that to the HHS Finance so that we can really evaluate, and I'll work with the counties.
Chair Liebling.
Well, Madam Chair, thank you. And the testifier noted, it would be a good strategy to just, move the bill on with this and send it and get a fiscal note. I mean, I'd actually really like to see what that fiscal note would say. But the testifier told us that because the policy is so undefined, that we wouldn't even be able to do that. So I guess I would ask the maker of the motion, and just let me say, even though I think it's great for members to be able to work on bills on the fly, and in my committee, I don't have a 24-hour rule for amendments, because I think it's great to work on them. When we kind of do things on the fly, we also sometimes, don't think through fully what it is we're doing, and that might be the problem right here. So I would like to ask Representative Albright to have a better definition or withdraw the amendment so that we can actually continue to work on it. I bet Representative Noor would, we could ask him if he's willing to work with Representative Albright to define the term a little better so that we really could get a fiscal note. I'd like to do that.
I think it may be helpful. Representative Noor.
Thank you, Madam Chair. I'll be honest, this is a little frustrating to me. We are very specifically talking about cash assistance here. We are literally putting money in people's pockets. And this is a really critical program for so many people. I mean, we're hearing this number of 30,000 people. This is really, really important. And we're talking about how important it is for people who have substance abuse disorder to receive the help they need. And yet we have this chance to make that happen, and we're saying that, but we don't really want to do that. I just see a lot of hypocrisy here right now. This is incredibly frustrating to me. I assume, we talk about the opioid epidemic, and certainly there are people who are affected by the opioid epidemic, but I would actually talk about the addiction epidemic, because I bet every single person around this table has been affected by the addiction epidemic. And that's really what we're talking about here. We are talking about this epidemic of addiction. And I don't know about all of you, but I certainly have dealt with people very close to me in my life who have dealt with addiction for over 30 years. And you know what we know in my family? That the worst thing to do is put cash in their pocket. That is the worst thing we can do for them. That does not help them to put cash in their pocket. What helps them is to support them, get them the help they need to move forward. I understand the intent of this, that we don't want to deny those benefits, but if we're not going to deny those benefits, then let's guarantee they're getting the help they need.
So, seems like we have someone else like to testify. Ms. Webster?
We've been the pain, so wanted to show that we don't.
You know, I think one of the things that we could think about doing, you know, because the fact is, we put a huge amount of responsibility onto our counties who are really struggling, and that's around the state. I mean, the more rural, the less resources they have. And, you know, we do want to support individuals and families and get them the resources that they want. But I think that what we're looking at is an unfunded mandate that we're putting on counties. And so, you know, maybe the author of the bill and Representative Albright can work together as this bill continues to move through to the next committee to see, you know, what is resources? What is the cost associated with the many different resources? I'm going to just stop there and let Ms. Webster speak.
Thank you, Madam Chair and Representative New. You know, you just mentioned putting cash in people's hands, and actually, if you look at line 2.3, we actually don't put cash in people's hands when they're convicted of a drug offense. The assistance is vendor paid, so it goes directly to their landlord or to their utilities, which ensures that it's actually a very burdensome process for the counties. It's one of the most burdensome things we do in this program, but it gets at that concern you have that cash would not be spent on basic needs such as shelter.
So we have, Representative Noor, what would be your preference, please?
Madam Chair, I'm willing to work with Representative Albright to make sure that we do have that language in and ensuring that the counties have got the right support services that they can administer this program. If you're willing to withdraw the motion now, I'll be more than willing before it comes to HHS Finance to walk through the process and come up with the language in that committee.
Representative Albright, are you willing to continue to work with Representative Noor and withdraw the amendment, or how would you like to move forward?
Representative Noor, while I appreciate the sentiments of working with you on this, and I think that in concurrence with the amendment that I've offered orally, I don't see any reason why we can't work on the language while still putting my oral amendment on. I think it, as Representative New said, I'd like to find out what a fiscal note looks like on this with that change of that one word, because I think it does bring into better clarity where our priorities are as a state in terms of, are we willing to provide, if in fact the fiscal note comes back that there is a need for additional support to the counties? I'd like to know what that amount is, because as Representative New said, and I wholeheartedly agree with her, this is about addiction on a whole myriad of fronts. And so while I appreciate the sentiments that have been expressed by a number of the members of this committee, I am unwilling to withdraw my oral amendment at this time, and I'm also asking for a roll call on the amendment.
Great. A roll call has been called on the amendment.
Yeah.
Okay, Chair Liebling.
Thank you, Madam Chair. And I'm glad you did that, Representative Albright, because I was just going to say, I think we could put this on, and so I'd encourage all the members to vote for it. I hope that you, and we can't get a fiscal note until you and Representative Noor come up with language. When you get an amendment together, we will get the amendment fiscal noted. And so members should vote for this amendment. And then, Madam Chair, I'm also going to ask roll call on the bill, because if we're not being hypocrites, all of us should then be voting for this bill. So since Representative New brought up, being a hypocrite, if you're serious about working on this problem and serious about the issue of addiction, then everyone should be voting for the bill.
Any further discussion on the oral amendment? Okay, so why don't we take the roll on the oral amendment first?
Chair Moran,
Yes.
Vice Chair Morrison,
Yes.
Minority Lead Keel,
Yes.
Representative Albright,
Yes.
Representative Backer, Representative Bonner,
Yes.
Representative Edelson, Representative Fisher,
Yes.
Representative Freiberg,
Yes.
Representative Liebling,
Yes.
Representative Loeffler,
Yes.
Representative Mann, Representative New,
Yes.
Representative Pearson,
Aye.
Representative Pinto,
Yes.
Representative Robbins, Representative Schumacher,
Aye.
Representative Schultz.
Yes.
Okay, there have been 14 yes and 0 no's. The oral amended is adopted. Okay, is there any further discussion on the bill as amended?
You need to make your roll call motion.
Okay, being no further discussion on the bill as amended, we'll go to the roll call.
Chair Moran,
Yes.
Vice Chair Morrison,
Yes.
Minority Lead Keel,
Yes.
Representative Albright,
Yes.
Representative Backer, Representative Bonner,
Yes.
Representative Edelson, Representative Fisher,
Yes.
Representative Freiberg,
Yep.
Representative Liebling,
Yes.
Representative Loeffler,
Yes.
Representative Mann, Representative New,
Yes.
Representative Pearson,
Aye.
Representative Pinto,
Yes.
Representative Robbins, Representative Schumacher,
Aye.
Representative Schultz.
Yes.
Okay, there being 14 yes and 0 no's, the motion prevails. House File 1719, as amended, is recommended for re-referral to the Committee on Ways and Means.
Thank you, Madam.
Representative Noor. Okay, the next bill is House File 1892, Representative Morrison. Representative Morrison, would you like to move your bill?
Madam Chair, I move that House File 1892 be recommended for placement on the general register.
Okay, we have the bill before the committee. Representative Morrison, please present your bill.
Thank you, Madam Chair. Members of the committee, thank you for allowing me to present House File 1892, which is a bill I think is very important in ensuring pregnant women continue prenatal care and they and their babies have good health outcomes. I also want to thank my co-authors, Representatives Mann, Baker, Hamilton, Pinto, and Dabney. Currently, healthcare professionals or social service professionals are mandated to report a pregnant woman to a local welfare agency if she tests positive for any controlled substance other than alcohol or cannabis. Unfortunately, mandatory reporting of controlled substance use after prenatal screenings leads to distrust of providers and avoidance of prenatal care during pregnancy. House File 1892 would amend those requirements to eliminate barriers to accessing prenatal care and improve access to addiction services. Pregnant women who have substance use disorders should have access to comprehensive services, including prenatal care, drug treatment, and social support services. These women often have other psychosocial risk factors and comorbidities that need to be addressed in order to ensure they successfully, that their substance use disorder is successfully treated. These women often do not seek prenatal care until late in pregnancy or not at all because they are worried that they will be stigmatized or that their newborn will be taken away. I believe that targeting women who use drugs during pregnancy for criminal prosecution drive women away from treatment vital for both them and their baby. As a practicing OBGYN, I can tell you firsthand how important trust is in the doctor-patient relationship. Women with a substance use disorder need health care, not condemnation. For that to occur, women must believe and know that their provider is on their team. The worst possible thing for them and their baby is to avoid prenatal care. This bill provides a step in that direction. And I have a colleague from the American College of OBGYN here to testify as well.
Madam
Chair.
Welcome to the committee. Please introduce yourself and tell us who you're with and proceed.
Madam Chair and committee members, I am Dr. Siri Fiebiger, and I'm the legislative chair of the Minnesota section of the American College of Obstetrics and Gynecology. We represent over 1,000 women's healthcare providers here in the state of Minnesota, and we are here in support of House File 1892. I'd like to explain why we feel this is such an important step. The maternal mortality rate here in Minnesota is 14 per 100,000. And though that is lower than the U.S. average of 24 per 100,000, it's still unacceptably higher than any other developed country. And it's twice that of Canada's at 7 per 100,000. It's more dangerous to be pregnant and give birth now in the United States than it was a generation ago. Data from our Maternal Mortality Review Committee here in Minnesota shows that mental health and substance use disorder are among the most common causes of maternal death here in Minnesota. And we know that adequate prenatal care is essential to optimizing the outcome of any pregnancy, and this is especially important for those that are complicated by mental health and substance use disorders. However, according to a 2015 survey by the Minnesota DHS, mothers of babies with neonatal abstinence syndrome were 12 times less likely to seek prenatal care, and 20% of mothers using opioids are not diagnosed until either delivery or after here in Minnesota. March of Dimes studies have shown that women avoid or delay prenatal care because they fear a punitive response. The current law requires that we healthcare providers report positive screens for any substance other than alcohol or THC. Removing this language will remove a real barrier to patient-focused care. When a patient can trustingly share her history with her healthcare team, she has the pivotal opportunity to get the care that she and her newborn will need to adequately address her chronic relapsing disorder so that she and her family will not just survive intact, but go on to thrive. Thank you.
Thank you so much for your testimony. Is there anyone else in the audience who wishes to testify on House File 1892? Representative Albright.
Thank you, Madam Chair. And Representative Morrison, I know this is probably a technical question, but you strike line 1.14, which talks to the use of THC, which is one of the agents in cannabis. But there is another one, another element in cannabis that also is considered. I'm wondering, part one, why that, maybe it's already stricken and it's not considered, and so it's not necessary here, but I'm also wondering if this would include, or it's already been stricken in terms of CBD and those types of elements from hemp, which is a close cousin to marijuana.
Representative Morrison.
Madam Chair, Representative Albright, I apologize, I don't have the bill language in front of me, but there's not mandatory reporting for THC or CBD.
Representative Albright.
Okay, so then my question is, I think Representative Bonner just provided you with the language, but you might want to amend your answer, given the fact that tetrahydrocannabinol is identified there.
Oh, this is the
Representative Morrison?
Madam Chair, Representative Albright, the intent is to remove reporting of all substances.
Representative Morrison, so let me be clear then. All substances reportable under what definition?
Representative Albright, we're going to have House Research, Mrs. Sutherland to respond.
Thank you.
Madam Chair and members, striking the language in the existing statute on page 1, lines 13, 14, and 15, that is an exception. That's an exemption. So under current statute, these professionals do not have to report the use or consumption of THC or alcoholic beverages, but they do have to report everything else. And so by striking that language, that makes them exempt from reporting for all controlled substances or excessive alcohol consumption. So that was an exception, so we're striking the exception, making it all substances that these professionals will not have to report.
It's kind of like math, so 2 negatives equal a positive. Is that
Kind
what
of,
I'm
yes.
working on here? Thank you, Representative Morrison.
Thank you. Representative Noor.
Thank you, Madam Chair. And Representative Morrison, I'm just wondering on the definition. It says specifically, if the professional is providing the woman with prenatal care or other health care services. My question is that prenatal care, is it possible that that is a one-time event, that prenatal care? Is that defined? And I ask this because my concern is that if there's a single event, if there's a single visit of providing that prenatal care, I would be concerned that there is not a follow-up and a monitoring. But I certainly agree with the intent of the bill that if there is ongoing prenatal care, clearly we want to care for that woman and that baby. So I'm just wondering if you have any insight or clarification on that.
Representative Morrison.
Madam Chair, Representative New, it certainly could refer to a single visit, and boy, what an opportunity that single visit could be if you could gain that woman's trust and get her into the healthcare system. Thank you for your question.
Representative Albright.
Thank you, Madam Chair. Representative Morrison, as a medical professional then, to follow on to what Representative New said, if someone presents themselves with a substance disorder, my presumption is, as a medical professional, you would seek out the proper treatment or introduction to treatment for that substance abuse. Correct? Correct?
Representative Morrison.
Madam Chair, Representative Albright, you can't always diagnose a substance use disorder in a single visit, but certainly if that became apparent during the course of that visit, that would be part of the treatment plan.
Thank you.
Any further questions? All right, so there being no further discussion, Representative Morrison renews her motion that House File 1892 be recommended for placement on the general register. All in favor, say aye.
Aye.
All opposed? The motion prevailed and House File 1892 is recommended for placement on the general register. Thank you. Our next bill up is House File 1535. Representative Morrison, would you like to introduce your bill? Move your bill.
Madam Chair, I move that House File 1535 be recommended for re-referral to the Committee on Ways and Means.
Okay. So we have the bill before the committee. Representative Morrison, please present your bill.
Chair Moran, members of the committee, House File 1535 provides Medicaid coverage for home environmental assessments and for durable medical equipment to treat poorly managed asthma in children. Asthma is a cruel disease. At its worst, it involves attacks of acute breathing difficulties. It often requires intense respiratory treatment and ongoing medications. Anyone who has witnessed or experienced an acute asthma attack knows the terror it can induce, especially for children and their parents. We can do better in treating this common disease. This bill provides coverage beyond the core medical treatments required to manage asthma. It looks at where kids live, their homes, and assesses the environmental triggers that may be contributing to their condition. It provides practical, low-cost equipment and supplies to parents and caregivers to address the allergens in a child's home that trigger attacks or aggravate symptoms. This bill has been introduced before several times, I understand. As a physician, it honestly confuses me why it has not been passed. Besides supporting good, effective health care, it saves money. It's time to pass this common sense bill. Everyone wins: children with asthma, their families, healthcare providers, insurers, and taxpayers. I have a testifier with me today who plans to be brief in her comments. Thanks for being here.
Hi, welcome to the committee. Please introduce yourself for the record, who you're with, and proceed with your testimony.
Thank you, Madam Chair and members of the committee. My name is Lisa Smestad, and I am the manager of the Lead Hazard Control and Healthy Homes Unit in the Minneapolis Health Department. This bill would provide Medicaid reimbursement for home environmental assessments done by specifically trained public health staff in residences where MA-enrolled children with insufficiently managed asthma live. Under this bill, coverage for appropriate allergen-reducing durable medical equipment would be provided. We may not think of HEPA-filtered vacuum cleaners and allergen-blocking mattress covers as medical equipment, but for these children, they are. Even with the best medical care, when a child is sent back to a home environment that contains asthma-triggering materials, things like mold and mildew, smoke, rodent waste, or certain insects, the condition does not improve, and repeat visits for urgent and emergency care continue. The Minneapolis Health Department and the St. Paul Ramsey County programs and others like them across the state have a proven track record for helping families reduce environmental triggers in their homes. Statewide, 1 in 14 Minnesota children have an asthma diagnosis. Studies done by the American Lung Association and the Minneapolis Health Department found that our public health home assessment program saved $2.19 for every dollar spent. Grants work great for pilot projects, but for funding long-running programs that produce reliably positive results and set a best practices baseline, ongoing predictable funding is a necessity. MA coverage is a great place to start. In summary, the key to successfully managing childhood asthma is high-quality medical care coupled with the public health in-home services as outlined in House File 1535. This proposal reduces student absenteeism, which, by the way, is the most common reason for elementary-age school absences. Do you want me to read Dory's? Sure. I'd also like to read a small portion of Dr. Dory Baker, who had to leave.
Okay, thanks.
She is the Associate Clinical Director of Asthma at Children's Minnesota. Children's is the state's largest provider of pediatric health care. At Children's, each year they treat 4,000 children diagnosed with asthma. Of those, 800 participate in their asthma clinic. For asthma clinic patients, they complete an asthma history, review medication and compliance, and do a respiratory exam to determine if their asthma is under control. They also discuss with the patient's parents and caregivers the home environment to assess possible exposure to asthma triggers. When appropriate, they refer patients to Community Connect Social Services and Healthcare Legal Partnership for assistance with housing and free legal service. The Community Connect program may make additional referrals to the Minneapolis Healthy Homes or Ramsey County St. Paul Public Health for a home assessment and remediation as needed. In 2016, Children's Community Health Needs Assessment identified asthma as a community health need. Treatment of asthma is a health equity issue as well. Minnesota children living in low-income communities are more likely than children living in higher-income communities to have been hospitalized for asthma, and our American Indian and African American teens are more likely than others to have been diagnosed with asthma. We have found that we can multiply the benefits of our specialized asthma medical care by partnering with city and county public health departments who provide healthy home environmental assessments. Asthma is one of the conditions that is best treated through a holistic preventive approach. This bill supports that approach. Thank you for your time and consideration today, and I'm happy to answer any questions.
Thank you so much for being here to testify. Is there anyone else in the audience who would like to testify on House File 1535? Members, any further discussion? Any? All right. There being no further discussion, Representative Morrison renews her motion that House File 1535 be recommended for re-referral to the Committee on Ways and Means. All in favor say aye. Aye. All opposed? The motion prevails and House File 1535 is recommended for re-referral to the Committee on Ways and Means.
Thank you, Madam Chair and members.
Okay, why don't we take maybe a 10-minute break, bathroom break, food, some water or something? 10 minutes. Let's be back at, pardon me? Yes, let's be back at 3:45. We are now in recess.